Okay.
I I'm really happy to join everyone this evening. I'm Caitlin. I'm part of the ownership family at St. Francis Herb Farm. So as you may or may not know, we're a second generation family business in Ontario. Yep, we're in the Ottawa Valley. We're about 40 minutes outside of Algonquin Park. So we're quite rural and we do have a farm. So yeah, I'm really happy to join Dr. Brianna Lutz this evening, who is a great naturopathic doctor. She's been working on our team for a good few years now. I think about 7, 8 years, Dr. Brianna?
Next year
And
will be 10. Next year will
10?
be
Oh
10.
my
Yeah,
gosh.
next year will be 10. Yeah.
Yeah, there you go. Not only is Dr. Brianna an excellent naturopathic doctor, she's also a registered herbalist and she specializes in women's health. And she works a lot in her practice about women's health. So she's very passionate in accompanying women on all health issues. And tonight we're going to do a deeper dive into PCOS. And, we know PCOS, it's a tricky one, but I think tonight Dr. Brianna is going to give some good insights about lifestyle and herbs and what can be done from that perspective. If you haven't heard Dr. Brianna before, you're in for a treat. She's an excellent, approachable educator, and we're so proud to have her part of the St. Francis team. So enjoy this evening, and I can help out in the chat if you have any questions. I'll try my best to answer. And then in the end, we will leave a few minutes for Q&A as well.
Yeah, you betcha. Yeah, so feel free to engage in the chat. I might not be monitoring as often, but Caitlin will be able to kind of monitor and then kind of curate the questions as well. So certainly we can get to and have a bit of a Q&A at the end, but certainly like if a question comes up during the presentation and what I'm saying, I might not get to your question live, but at least I'll create some room for questions because I may be coming up to your question in a following slide. Yeah, so as Caitlin mentioned tonight, we're going to be talking about PCOS or polycystic ovarian syndrome. And while we're looking at it as like a hormonal condition, really understanding where this root cause piece is coming from. So there's a lot of buzz around insulin resistance, insulin sensitivity, but understanding how that plays into a hormonal perspective and how we're seeing it be, exacerbated in different hormonal symptoms. So for this evening, the outline is I just want to have you understand what PCOS is. And then I want to dive a little bit into the diagnostic criteria. Please move the mouth. Is my mouse away from the slides now? I'll just make sure that that's corrected before I move on. Mouse on the slides. Okay, excellent. Okay, so the diagnostic criteria for PCOS, because again, I think that helps us weigh in where this is coming from, and there might be some myths around PCOS as well. So, spoiler alert, you don't actually have to have cysts on your ovaries to have PCOS. So sometimes people will get dismissed, or you don't look like you have PCOS. I know a lot of doctors have said that to some of my patients. You don't look like you have PCOS, so therefore you can't have it. We'll talk about some of the hormonal patterns of PCOS and what that looks like. And then we'll talk about basically how I frame a treatment strategy and different considerations. So, from a lifestyle perspective, but certainly as a herbal company, we really want to highlight some of the herbs that are very supportive for the condition. I actually added a last minute slide because I'm like, oh, there's another herb that we still need to talk about because I've done this material before. But there's so many different herbs that can be really suited towards the condition, but how many herbs globally could be really supportive overall for this condition? Okay, so in terms of what PCOS is, polycystic ovarian syndrome, again, it's a bit of a mouthful, but this is an umbrella of a diagnostic criteria. And as I mentioned, the name does pose some limitations. So you do not actually have to have cysts on your ovaries to have PCOS, despite what the name says. So there has been some rumblings around renaming this condition. I don't know what we'll rename it to because again, there's so many different criteria. And we say this is like a disease or a condition of many faces as well. So we can have lean PCOS or adrenal PCOS or this insulin resistant type. So not every type of PCOS has the same inclusion criteria, or could this inclusion criteria be something else? So a lot of times we're talking about in irregular cycle, or that somebody's not ovulating being part of PCOS, but could there be other reasons that they're not ovulating? And so we're missing a thyroid condition and they actually have a thyroid condition and they don't have PCOS. So again, putting our little detective hat on when it comes to this from a practitioner perspective. And because of the wide diagnostic criteria, not all PCOS types should be treated the same. And we'll talk about kind of how we're looking at PCOS for the intensive purposes of tonight's conversation. Okay, so, and I actually like draw this out for my patients. I draw a little umbrella and my 4 little columns of these different diagnostic criteria for people. So part of these diagnostic criteria is technically you only need to have 2 of one of these buckets or one of these bullets to be diagnosed with PCOS. So again, that poses some limitations. So the first is going to be cysts on the ovaries, and cysts in PCOS are very distinctive. Okay, they're not like a lot of we can have different ovarian cysts, we can have blood-filled cysts, but the cysts in PCOS are kind of like a pearl necklace or like string or beads on a string. Sounds glamorous and sounds beautiful, but probably not something that we're looking to. So multiple cysts or follicles on the ovary, often like a pearl necklace. So sometimes we can also see this translating to bulky ovaries, or an increase in ovarian volume. So oftentimes this is over like 10 cc or 10 cubic centimeters. Or we may also see this as an increased hormonal marker. So a hormone called AMH, or anti-Mullerian hormone, is the hormone that our eggs or our follicles produce. So sometimes we're seeing really high AMH levels, and we're like, well, that's curious. And I think in Australia, they've actually changed using AMH as a diagnostic factor rather than getting these women to do ultrasounds, because again, sometimes that's a limitation of access to this testing. So that's one bucket. Another inclusion criteria is going to be an irregular cycle, or what we call anovulation. So you're not ovulating or oligo-ovulation, meaning you might not be ovulating on every single cycle. So typically we're seeing this as like a longer cycle. So maybe rather than like a classic 28-day, we're seeing 32 days, 36 days, or somebody's like, oh, I consistently like miss a period, like every other period I'm missing. So that could be, again, an inclusion criteria. For me, I do a lot of work in fertility. So we're really looking quite consistently at, are you ovulating, and looking at different markers if somebody is ovulating. So whether that be temperature, or whether that be those P strips that you're using, or we're testing your progesterone levels to ensure that you've ovulated. Again, there's multiple factors that we can dive a little bit deeper. So sometimes that's part of a factor with PCOS is, again, people not getting pregnant. And we're like, oh, you're not actually ovulating. So again, that could be part of, yeah, on both ovaries. Okay. So then we're also looking at clinical signs, or what we call biochemical signs. So you could have the symptoms or presentation of excess androgens, or what we call like different types of testosterone. So hirsutism or facial hair growth, we kind of joke around, you're like your little chin friends just like pop up. This is different in like perimenopause. That's a different hormonal thing, but we're seeing chin hair or neck hair, hair around the belly button, like those kinds of things, kind of like very similar to like male pattern hair growth. Or we may see this as hair thinning or hair loss, especially in like a male pattern type. So frontal hair recession, or we're seeing like thinning at the crown, can be, again, a clinical sign of excess androgens or high testosterone. We can see biochemical signs, meaning we have blood work that shows you that you have higher levels in androgens. And that could be like elevated testosterone. This could be other markers that we use for testing testosterone. So the SHBG is sex hormone binding globulin. So we see that being really low in PCOS. Or DHEA is actually a testosterone-like compound that comes from the adrenal glands. So sometimes we talk about adrenal PCOS. We're seeing those androgens or testosterone coming from the adrenal as opposed to elsewhere in the body. Cystic acne could be another clinical sign that we see. And what I mean by cystic acne, it's kind of like a chin strap. So we're seeing it very much along the jaw. And it's not like the superficial little blackheads, it's deep, painful red acne, again, being signs of that higher testosterone or those androgens. Now, the last bucket or diagnostic or inclusion criteria is going to be insulin resistance. And I think this is the pièce de résistance of this presentation, is that we really need to focus on the insulin resistance because this is the underlying factor of PCOS. So while we're seeing all of these factors, like the irregular cycle or the increased testosterone or these cysts, all of it, especially in this classic type PCOS, is coming from insulin resistance. Now, some people are coming in to me talking about symptoms that they're having. So, like, I get fatigue after eating, or I get really unstable with my blood sugar, or I get hangry, or like, do I have insulin resistance? So, I take all of that into consideration, but sometimes I'm actually calculating their HOMA IR score. And that IR stands for insulin resistance. So, I take their fasting insulin, I take their fasting glucose, and I use that to create their HOMA IR score to determine their level of insulin sensitivity or insulin resistance. Okay, so how does blood sugar work? Okay, so you eat something, right? So you start digesting your food, break it down in your stomach. All of these your food is in your small intestine. So we liberate our glucose or sugars in our small intestine. So our body is detecting that we've eaten something and that our blood sugar goes up. Okay, so we absorb glucose into our bloodstream. We have high sugar in our bloodstream, and our pancreas goes, okay, we need to spit out some insulin. So then that insulin can tell the sugar to go from the bloodstream and into the cells. Okay, so we release insulin, and if everything's functioning properly, that insulin should tell our cells to absorb that glucose. Okay, so and then what happens is, again, our blood sugar goes low, it's stabilized, and then our cells have that glucose for energy. Now, if those cells aren't listening to the insulin, so they're insulin resistant, our blood sugar stays high because, again, the sugar is not going from our bloodstream and moving into the cells. So, again, our body is kind of constantly calibrating, being like, okay, our sugar is still high. We need to make more insulin, make more insulin, make more insulin until we get to a point where our body cannot do that. So we're shifting into diabetes. So insulin resistance, PCOS, can be a precursor to diabetes if we're not actually addressing this appropriately. Okay, so normal insulin sensitivity, we eat, we liberate glucose into our bloodstream. Our body goes, yep, our blood sugar is high. I'd like to use that for energy. We spit out some insulin. Or insulin circulates, tells us, yeah, bring that sugar into the cells. And if those cells aren't listening, then the blood sugar stays high, right? So chronically high levels of sugar is going to be problematic, right? Sugar is a very large crystallized structure. So we can see end damage to our kidneys, our eyes, those kinds of things associated with diabetes. Okay, so just to recap, too much glucose is absorbed in the blood. Pancreas has to produce more and more insulin to get that sugar into those cells. And so we can sometimes see receptors being downregulated, and insulin cannot get into those cells. And there's different proteins, different markers that help with that insulin sensitivity. And the reason that that's important, that GLUT4 that's on this slide, we can see some tools, some herbs actually helping with that GLUT4 activating to help with insulin sensitivity. Okay, so just an example of what a normal ovary is looking like and a polycystic ovary. So, the reason that we're developing these different cysts, these different structures, we're seeing changes in hormones is that chronically high or elevated insulin, when that's surrounding the ovaries are actually going to convert that to testosterone. So, we can see the insulin being directly related to causing the increase in testosterone. So while we have some tools and some great herbs, medications, those kinds of things that are helping to decrease testosterone or those different androgens, again, that target in especially in a classic PCOS should be going after that insulin resistance. We promote that insulin sensitivity. There's less insulin in our system. Therefore, we're not actually producing those hormones or seeing that hormonal cascade that's happening. So on this image here, you can see those cysts kind of stayed in the ovary. So I was talking about that bulky ovary where there's multiple cysts, multiple small follicles contained within the ovary. And how we can translate that to a hormonal chart. So what we're seeing here is what should be happening with our luteinizing hormone. Okay. I'll talk about that a little bit more on the next slide in terms of this beautiful orchestration and cascade that's happening from a hormonal perspective. But when we see this regular line of the LH, so day one is going to be the first day of a period, and our hormones are going to be nice and low at that point. Okay. So what happens, actually, I'm going to jump to the next slide and then I'll come back to that luteinizing hormone piece. So all of our hormones are kind of at their low point. And then first, what's going to happen is the brain is going to talk to the ovaries and tell it to do two things. A, to develop a follicle or an egg, and the second to produce estrogen. So estrogen is going to creep up and up and up and up and up and up and up through that first part of the cycle. And that peak in estrogen is what's going to trigger ovulation or that luteinizing hormone. So that peak in estrogen, we get this surge in LH or our luteinizing hormone, and that's going to tell our body to ovulate. Now, when we look at what happens with ovulation, you can think about that as being like a sunny side up egg where the yolk leaves and looks to get fertilized, and the egg white that stays around is what's going to produce our progesterone. No ovulation, no progesterone. Okay. So PCOS, we're seeing this discrepancy of estrogen and progesterone because they're not ovulating or they're not producing progesterone. We get little bits of progesterone, but again, we get our main production after ovulation. So again, that peak in estrogen is what's going to trigger that surge in LH, and that surge is what's going to cause ovulation. So if people are looking to track ovulation, so I was talking about those P tests, that's the hormone that we're looking at when we test the urine. So people, you should be getting clear negatives, like negative, negative, negative. And then around mid-cycle, we're going to see that shift and change, and we're going to get positive. So that LH surge, and then it should die off after that. With PCOS, it's very, very confusing because I'll just go back to that previous slide. Luteinizing hormone is high the whole time. Okay. So that's actually what's happening. Again, insulin is around the ovaries. We're getting a higher production of luteinizing hormone. And so one kind of like tip off for me if somebody is in my office and they're like, I've been trying to get pregnant for a while, so I bought those P tests on Amazon, and I've been testing it, but I'm like squinting at the test and I don't know, like, is it positive, is it not positive, I can't really tell. And they're like, and I feel like day 3 I'm already getting these positives, and I'm like, ooh, this might be PCOS, or I wonder why their luteinizing hormone is high or elevated in this part of their cycle. Again, that luteinizing hormone is coasting high the whole time, that we don't actually get a surge that's triggering ovulation. So they don't actually ovulate. So, it sounds counterintuitive that you're saying, well, that's the ovulatory hormone, but they're not ovulating. It's just not properly timed. So again, it's kind of maturing those follicles, maturing those follicles. So what I talk about, like, especially with the cysts on the ovaries or that pearl necklace, it's like your body really wants to ovulate, but it's like, huh, just kidding. Oh, just kidding, huh, just kidding. So you have a lot of just kiddings around the ovaries or inside the ovaries as well. So again, from this, and I know I'm sorry, the colors are very similar. It's like this muted, nice tone. But again, this kind of top or that whole surge, that nice high one, that's PCOS versus like the normal one that we're seeing, kind of like this lightest color is a typical cycle where it's low, 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 and then we get the surge through the middle, and then it tapers off, or again, you get that drastic spike. Okay. Just seeing how I'm doing for time. Okay. So let's see. Okay, so as I was mentioning, no ovulation, no progesterone. So we're seeing a bit of this, ratio of being off of our estrogen and progesterone. And I think this is a really good conversation because especially in like the natural health world, we're talking about like estrogen dominance, which is a phrase like I don't love because I like being really specific, because estrogen dominance could mean a progesterone deficiency, as such in the case of PCOS. Okay, so it's not that they have too much estrogen, and I would actually counter to the opposite, but it's because they have such little progesterone because they're typically not ovulating. So we get this discrepancy. Um, Oftentimes what we're seeing is individuals with PCOS actually have lower levels of estrogen. So, or they might not have true insulin resistance PCOS, but they might have low estrogen kind of chronically, and that estrogen is not reaching that peak to help trigger ovulation or to help trigger that luteinizing hormone there. So again, other considerations, and again, a lot of, again, in the natural health world, of using things that help to detox our estrogen or eliminate our estrogen might not be the best idea in PCOS, again, because it's not because they have too much estrogen, but it's because they don't have as much progesterone because they're not ovulating. What we might see, or where we see the exception to that rule, is if you think about the uterine lining like a brick wall, estrogen are the bricks and the progesterone is the mortar that seals everything in. So we'll see what we call estrogen stacking. So we get an accumulation of estrogen. We don't have ovulation, so we don't produce progesterone to trigger a withdrawal bleed or a period, right? So progesterone drops, and that's what triggers a period or our next cycle if we don't get pregnant on that cycle. So then what happens is our estrogen is going to continue to grow, continue to grow, continue to grow. And you can imagine a brick wall without any mortar, that those bricks are just going to fall out. So somebody's like, yay, I finally ovulated because I got a period. Not necessarily. That might have been an estrogen withdrawal bleed because there's no mortar. Those bricks were really unstable. That uterine lining was really unstable, and then everything fell out. So again, in that case, then we may not see ovulation as well. So again, that estrogen stacking from cycle to cycle. So that's where it may appear as estrogen dominance, but it's not truly in that case. Okay, so when we look at treatment strategies and considerations, first and foremost, oftentimes my goal is going to be promoting insulin sensitivity. Now, when people come in, it's not like that's sometimes a top priority. For me, it's like, I need to get pregnant like yesterday, or it's a lot of the problematic symptoms, like they have those excess androgen, so acne, hair growth, hair loss. Or some people are like, I've never really had a predictable, reliable period. And for me, that could be really, really important, right? My goal oftentimes with PCOS is having at least 6 periods a year. And this is in the case if somebody is not on external hormones, okay? If somebody is not regularly bleeding, again, because they're not ovulating, they're at higher risk for those cells becoming abnormal. So we want to make sure that people are either inducing a bleed, so sometimes they'll get a short dose of progesterone to trigger a bleed, or they're on continuous hormones to prevent the fluctuation. So whether that's an IUD or it's a combined hormonal pill that helps to regulate, I shouldn't say regulate those hormones, but gives like a false protection. So it gives a true protection, but gives like a false period. In that case, it could be a factor, right? So my goal is I want to make sure that those cells are stable. They have good uterine protection if they're not regularly bleeding. Then kind of like long-term goals for me, as we talked about, insulin resistance can be a precursor to diabetes. I don't love the term pre-diabetes, but we know that there's this huge hormonal or like insulin component bubbling under the surface, and then it's not being addressed until you're like above a 6 or above a 7 of your blood glucose, where your doctor starts paying attention and like, hey, now you have diabetes, and then we're using different medications for that. And then, as I mentioned, so again, the uterine protection that we're looking for. And then also, if somebody has PCOS, they have low estrogen, I want to mitigate risks associated with not ovulating and risks associated with low estrogen. So continuous low estrogen, we can see issues with like higher risk for fracture, higher risk for cardiovascular disease, higher risk for dementia and Alzheimer's, because estrogen is very protective to those tissues. It's bone protective, it's heart protective, it's brain protective. And also risks of not ovulating. And I think we don't talk about this because sometimes we only talk about ovulation in the context of getting pregnant. And when I was in naturopathic school, I was working up a hormonal condition for a patient of mine, and I told the supervisor, I want to test her progesterone to see if she's ovulating and then adjust her treatment from there. And he had asked me, well, is she looking to get pregnant? I'm like, well, no. He's like, well, then why does it matter if she's ovulating? And we have so many benefits of progesterone that we don't really talk about. Progesterone is very nervous system protective. So it can potentially help reduce anxiety. And we can see like PMS, when progesterone drops, we may exacerbate or we might see increased anxiety. That sleep architecture, so progesterone has a role in that. So usually with like perimenopause, when progesterone is one of the first things to drop, we start seeing like sleep disruption, and that classic like wake up between 1 and 3 and want to solve all the problems of the world. That's that progesterone dropping. We see like great immune benefits of progesterone, and I can go on and on and on about progesterone. So again, me mitigating any of those risk factors associated with that. So treatment considerations, nutritional considerations is a huge point, right? We want to support people's blood sugar. So I would say commonly we're looking at more of the restrictive aspect of like, okay, well, for me, I'm looking at where are your refined sugars, right? So like the simple things, the high fructose corn syrup, those things. But the people who are coming to see me are often already doing that. So then we're getting a little bit deeper in how do we manage and stabilize blood sugar or blood glucose. And I saw a question pop in like, would the keto diet or really limiting carbohydrates help with PCOS? We're actually finding to the contrary. So it was old research that really restricting carbohydrates was the approach to PCOS, insulin resistance, diabetes, kind of that spectrum. However, limiting carbohydrates, we're losing out on other specific nutrients or supportive factors like fiber. And I'd say that's huge, huge, huge when it comes to PCOS. So we're looking at the types of carbohydrates, right? We want complex carbohydrates, things that are really rich in fiber, things that have additional nutrients or benefits that way. So a lot of the myths, I should say, a lot of the research or previous support or things that your doctors say you should do for PCOS, we're actually finding can be more harmful in certain cases. So a really strict carb elimination or carb removal, and like really, really high calorie restrictive diets, we're actually finding to be not supportive for PCOS either. So we're looking at like high nutrient density, blood sugar stabilization, where we're really focusing on protein, healthy fats, and then fiber as a really strong component. And I always tell people to eat breakfast, I'd say, and especially high protein breakfasts are very, very supportive for your hormones and insulin resistance. Um, I'll come back to that question about fats. So strength training, muscle is a hormonal tissue. And you can kind of think about muscle as like the sponge for glucose. So muscle is also kind of like your kiss of longevity. That's going to prevent hip fractures. It's going to stabilize your body, help with balance support. And I'd say a lot of people, it's like peak bone density and like mid 20s to 30s. And again, we want to ensure that we are strong and we're building muscle. And so that is going to be really supportive for insulin, preventing insulin resistance or reducing insulin resistance. I was actually at a store today because I'm in Manitoba right now. That's why I'm in a lovely hotel room. But we were talking about different nutraceuticals or things that this store owner was on. He goes, "Oh, I've been watching my sugars with berberine and these various factors." He goes, "When I go for a walk, it helps drop my sugars." I'm like, there you go. So again, movement strength training is great. No symptoms worse. Yeah, we can come back to that. Key nutrients, vitamin D is going to function more like a hormone than it does a vitamin. We're seeing that being supportive for insulin sensitivity. We're seeing that being supportive for ovarian support, hormone production. And when I'm talking about like B9 and B12, sometimes we're seeing this being deficient in those with PCOS, magnesium as well. And I would say if somebody is on a combined hormonal pill, this is depleting nutrients as well. So if somebody is doing that to like mimic their cycle or have that uterine protection, we can see that being depleted these other nutrients as well. Magnesium, type of magnesium, I tend to go to like a glycinate, tends to be the most easy for people to take. So insulin sensitizing agent, so whether that is uh, pharmaceuticals, whether that's nutraceuticals, whether that's herbs, anything that's going to be really supportive for promoting that. So we're seeing that with medications like metformin. Berberine is often comparable to metformin. We're seeing myo-inositol. And again, looking at that nutrition piece and then our herbal support there. Okay, so as I mentioned, those insulin sensitizing agents, myo-inositol, berberine. Interestingly, berberine is derived from herbs. Golden seal, Oregon grape, bloodroot, so sanguinaria, all of these contain berberine. And then we're just concentrating that berberine and isolating it from other constituents. So it's actually your good old herbal medicine. We'll talk a bit, and these are kind of the next slides that we're getting into. So our Canadian bitters, medicinal mushrooms can also help with that, and then licorice as well. So we'll talk a little bit more about that. I just want to see how I'm doing for time. We're doing really good. Okay. Canadian bitters. If you're new to like St. Francis, you're new to these different herbal things, welcome. I could do a webinar just on Canadian bitters. I love Canadian bitters. Caitlin's nodding because I'm sure she's heard me talk to death about Canadian bitters. A lot of times we're thinking about this for just overall digestive function. However, we're seeing really good benefits for a lot of metabolic factors, so related to insulin, to glucose, etc. So when we look at the different mechanisms that Canadian bitters is working on, we overall benefit is we get a more steady release of glucose and then more stable blood sugar with that. We see this modulating insulin, and a big factor of this is we're regulating this digestion hormone called CCK or cholecystokinin. Okay, so CCK is going to basically affect our balance of blood sugar, or the fancy way of saying it is glucose homeostasis. And we're doing this through a couple different digestive hormones. So insulin, and then another kind of key player called glucagon. In med school, when we're learning all these different terms, glucagon is get the glucose gone. So that can be supportive for, again, reducing the sugar in your bloodstream. And then this can be also very supportive for sugar cravings. So PCOS, insulin resistance, a common concern, especially with people trying to modulate their nutrition, is like, it's really hard because I constantly crave sugar. So this can be another layer layer, both working on those hunger fullness hormones, our glucose hormones, that we can get better benefit and support people in making those different lifestyle choices or lifestyle factors. So again, we get more steady release of blood sugar through great digestion with the Canadian bitters. We're modulating insulin, as I had mentioned, and CCK is our fullness hormone. So we're actually increasing our fullness hormone, so better satiation with meals, and we're decreasing something called ghrelin, which is like our hunger hormone. What's really cool is not only do we see benefit with the sugar cravings, with again these digestive hormones like CCK, but bitters is actually really great at kind of restructuring our taste perception, because we are a culture that doesn't have a lot of bitter foods in our nutrition, and there's sugar in everything. So as we start taking bitter compounds, this is actually looking to restructure, reclimatize our palate. So sweet things start tasting almost too sweet, and we're developing a taste for, again, those more like bitter foods. And I remember like taking bitters consistently. I was like, broccoli has never tasted so sweet, or like never as like diverse in terms of flavor. I don't just taste bitter, I taste all of these other things associated with this food. Again, so yeah, with sugar cravings, and CCK, that fullness hormone, hunger hormone. So I think there's a few questions just about bitters. I think Caitlin's kind of covering a few of them in the chat. Not safe during pregnancy, and some people are asking like, how long does it take before you're feeling a difference? From a digestive standpoint, I would say almost immediately. So definitely from, if somebody has digestive concerns, like consistent or chronic digestive issues, might take a little bit longer, but certainly we're looking to prime people's digestion. So you're taking it before you've eaten. But I kind of have the mantra of like better late than never. So even if there is bloating or fullness or those kinds of things, if you're taking bitters during or even after a meal, you're still going to get the digestive benefit. From a perception of like blood sugar, you may not notice that right off the get-go with taking bitters. It may take some time, generally a few weeks, that we're seeing improvements in that. And some people actually don't necessarily perceive insulin resistance in their body, or again, the manifestation and benefiting some of the PCOS symptoms, but it will be kind of a trickle-down effect. Okay, and I think there's more specific questions, but I'll come back to those. Okay, so licorice. Speaking of insulin resistance, we are looking at licorice to help with improving insulin resistance. When we we had the image and talking about how insulin tells our sugar to bring it into the cells, and there's different peptides or different receptors that help with that insulin sensitivity. Licorice actually improves that GLUT4 receptor. So basically, the licorice is telling our cells to listen better to the insulin so we can actually pull that glucose and bring it into the cells. So I think that's really interesting as well. Now, licorice in and of itself, it looks to decrease fasting blood sugar. So probably through that GLUT4 mechanism, but there may be a few other benefits or a few different mechanisms that way. We will decrease those insulin levels, again, especially if we have better blood sugar regulation, better insulin sensitivity. We can see those insulin levels going down. And then also lipid profiles. So again, we can see fatty liver disease as a result of insulin resistance. So this is like non-alcoholic fatty liver disease, or the NAFLD. So we get better cholesterol profiles, better triglycerides, because again, we're working on that insulin resistance, but B, licorice is very liver supportive. And then we see benefits in, again, lowering the triglycerides and cholesterol that way. What I love this about licorice. So it actually is a plant estrogen or a phytoestrogen. But when we look at plant estrogens, they're very modulating. So if estrogen is low, it increases it. If estrogen is high, it helps to lower it as well. So phytoestrogens, again, especially if somebody never actually reaches that peak of estrogen to trigger ovulation, licorice can be very supportive for that. So really, really love this herb. And then the last thing is also it helps to decrease testosterone. So licorice is an anti-androgen, meaning it blocks some of these different conversions and production of testosterone-like compounds. So you can see from a benefit of PCOS, this is a really beautiful herb. We see improved insulin resistance, which is that underlying factor. We see a really strong estrogen component to help support that hormonal cycle. And we see it decreasing testosterone, which is also associated with some of the side effect profile. So acne, again, the hair growth, hair loss can be really supportive with the licorice. Okay. There was a question there. Increase estrogen levels, counterintuitive. Go. If you have more estrogen to progesterone already. So good question. So if it increases estrogen levels, would that be counterintuitive if you have more estrogen to progesterone already? So estrogen is deficient often in PCOS, okay? So in building our estrogen, that's going to help with regulating ovulation. Our big thing is how can we regulate ovulation so then we can produce progesterone? And as I mentioned, licorice is also a modulator. So if estrogen is too high, it kicks off like our own estrogen from our receptor. But if estrogen is too low, it helps bind to that receptor to kind of increase the estrogen response. So it's a modulator, but it also is helping for ovulation. So great question. And then that's kind of how it works with regulating that. Okay. So then our anti-androgens, so we just talked about licorice. And then we have a few herbs that are blocking this conversion of testosterone to, I call them the dirty cousin of testosterone, like the DHT. I had a great conversation about this at a store today because people were curious about saw palmetto, because saw palmetto is often used in prostate formulas because in enlarged prostate, we're seeing that conversion of their nice, healthy testosterone to DHT, or the dirty cousin of testosterone. So when we see that DHT being elevated, that is what causes a lot of the problematic signs associated with testosterone. So that's the acne, that's the hair loss, that's the hair growth that we're seeing, or the hirsutism. So reishi is known to do this, acts as a 5-alpha reductase inhibitor. Saw palmetto, green tea is also something that does this as well. And another thing, and this is a kind of a newer addition to the slide, is in PCOS, we actually have what we call low sex hormone binding globulin, so SHBG. Now, SHBG is responsible for binding hormones in the bloodstream. So when we have really high testosterone or high DHT, for instance, if we increase that sex hormone binding globulin, we're going to get better quenching of that testosterone. So it's not coming out in the skin, or we're not seeing that as the hair growth or that kind of thing. So herbs that do this, again, from a nutritional perspective, we're recommending people are using things like flaxseed. So again, the flaxseed increases lignans, this increases the sex hormone binding globulin. Milk thistle does the same thing. So I really like adding milk thistle, again, especially if we're seeing some of those high androgen or testosterone-like symptoms, signs and symptoms, or again, in their blood work, that we can actually use the milk thistle to increase SHBG. Also, when people are put on a combined hormonal pill, it increases sex hormone binding globulin. So sometimes that's why people's skin is really great when they're on the pill. And when they stop a combined hormonal pill, then their acne flares, because again, they were kind of calibrated. Their sex hormone binding globulin was nice and high. We get that drop, and then all the hormones, we see it coming out in the skin. So that's really common when people discontinue combined hormonal pills, that we're seeing it result in acne, or kind of that post-pill discontinuation syndrome. Okay. So as I mentioned, milk thistle increases that sex hormone binding globulin, SHBG, reduces those increased testosterone-like compounds. And then it does have, interestingly, kind of a mild estrogenic effect, kind of similar to flaxseed, where we're seeing like this nice modulation of our estrogen. So I would say like milk thistle is almost like a super powered flaxseed. And two, milk thistle, we mostly have that association with being very liver supportive. So if somebody has, say, fatty liver disease associated with, fatty liver disease associated with insulin resistance, we're still supporting like overall liver function. If we're looking at kind of hormone modulation, or kind of supporting gently with hormone elimination, again, milk thistle can be very supportive. Okay. Black cohosh, I really love for PCOS, because it does have that modulation of estrogen. Now, black cohosh is not actually like a true plant estrogen or true phytoestrogen. It's actually working on the brain signaling. So, how our brain is talking to our ovaries. So, as we talked about, luteinizing hormone, that ovulation hormone in PCOS is high and high fairly consistently, and that's actually blocking ovulation. So normally early in the cycle, we should have your follicle stimulating hormone being about double your luteinizing hormone. And in PCOS, oftentimes it's the same, if not luteinizing hormone being substantially higher. So black cohosh actually helps to recalibrate that ratio. So we see better follicle development. So we get also better estrogen production, but we're lowering that luteinizing hormone so we can ideally support ovulation in those individuals. There's certain medications that have been studied to do this. So Clomid is a medication that people with PCOS are often prescribed to induce ovulation. This is kind of used in the fertility world. And black cohosh has been studied and compared to Clomid, and having better benefit with fertility, because it doesn't affect negatively the lining like Clomid might. So good benefit there in offsetting that ratio, very supportive for helping to regulate the cycle, really good estrogen support there. And we know that black cohosh is fabulous for reducing other hormonal symptoms like PMS. And also menopause is a different conversation, obviously. Also with PMS, say increased cravings or just general changes in behavior, irritability. Black cohosh is also very supportive of dopamine levels. And I know there's not a lot of herbs that we know necessarily do that, but black cohosh can be very supportive in that regard. So chase tree sometimes is hit or miss, but so let's talk about this. As we can see that higher doses can help with lowering luteinizing hormones. So sometimes if people are taking lower levels of chase tree, we're actually inducing that LH. So sometimes, and I've had some people like with PCOS, they're taking a low dose of chase tree and they're finding that their cycle is actually more irregular, because they're increasing that luteinizing hormone. So we definitely have to use higher doses to help lower that luteinizing hormone to help with that cycle regulation. When we look at, again, from a dosing perspective, we do have liquid options. We also have capsules. So the capsules are still whole herb extraction. So St. Francis does, pride ourselves on the global constituents. So we're not just isolating one constituent. And chase tree is a really good example of this, where if we do studies where we isolate a single constituent, it performs significantly lower than using a whole herb extraction where we get this synergy of all of these constituents. And we get way, way better benefit with whole herb extraction for chase tree. And again, as a capsule, we can get up to some of those higher dosages as well that may be more beneficial in lowering that luteinizing hormone. But again, this might be something that with a practitioner can help guide the proper dosing with that. But I would say the cohosh, we see, again, really good benefit with that LH FSH ratio. So again, yeah, available in both liquid herbal extract capsules, high potency 5-to-1 powder extraction there. Okay. So that leads us to questions. And I think that there are a fair few. So I'm gonna pop into here, and then Caitlin, I don't know if you want to take it away with passing questions kind of off to me, or if you want me to kind of pop through. So I'll let you kind of guide the Q&A with that.
Okay. Yeah, do you mind just popping onto the maybe the Q&A first
Oh, sure.
and then yeah, look down. Yeah, maybe we'll address those ones and then I can help you. I'll just go over to the chat and
Sure.
throw
Yeah.
you over a few from the chat, okay?
Yep, absolutely. Okay. Okay, so I have a question of, does insulin resistance or PCOS explain nipple discharge in age 65 or older? Okay, so really great question. And this is something I always do even with like a fertility screener asking about nipple discharge. Especially if it's like either one versus like both nipples. Prolactin is a hormone that is going to be responsible for like milk production. And so we can have elevated prolactin levels, and that can, regardless of pregnancy, that can cause nipple discharge. So I would always recommend getting your prolactin tested, and especially like bringing it up. Is it one? Is it both nipples? Usually with nipple discharge in both, it's probably an issue of elevated prolactin. Prolactin can get caught in the crossfire. So sometimes it's even stress feeding back to the pituitary that we're making a lot of prolactin, but I would say not necessarily PCOS. High prolactin can be misdiagnosed as PCOS because high prolactin can be a reason of not ovulating. But again, 65 or older, I would look into prolactin levels. Yeah, really, yeah, cool question. Okay, so I answered that. Okay. What are my thoughts on berberine as a supplement for insulin resistance? So I did have a slide on that. I did talk about berberine, again, plant derived. That concentrated format is fabulous. Berberine is a really, really well performing herb for insulin resistance. And I would say from a side effect profile, significantly better than metformin. So if people are kind of intolerant to metformin and then they switch to berberine, they can usually tolerate it a lot better. So I think it's a great supplement. Yeah. Not everybody with insulin resistance needs berberine. And sometimes berberine is more of a heavy hitter. So if somebody has really significant insulin resistance heading towards diabetes, yeah, absolutely. If you have insulin resistance in menopause and you're on bioidenticals, how can okay, or what if you have insulin resistance in menopause and you're on bioidentical hormones? You can still target the insulin resistance. Somebody could be on a combined hormonal pill in their reproductive years. They could be on bioidenticals. Either way, targeting the insulin resistance is really important. How do we reduce sugar? So we talked a few of those things. So the nutrition piece, so stabilizing blood sugar, protein, fat, and fiber, muscle. Muscle is going to be huge, especially in menopause. Again, that is going to be very supportive biocomposition wise, and also preventing progression of diabetes and all of those things as well. So we did talk about that. Okay. Are vitamin D shots a good idea if you have PCOS and are vitamin D deficient? I love vitamin D shots if people are deficient, especially if we can't get levels up. But I would say, and we do have the liquid drops from St. Francis, which I really love. I really encourage from a vitamin D perspective using drops. I find like the compressed tablets or the powders, because vitamin D is a fat soluble vitamin when it's in a fat carrier, like we have with St. Francis, really good option. If somebody is so deficient and we can't get their levels up from a supplemental perspective, we can use injections, and I do that in my practice as well. So yeah, it's a great option. And again, as I mentioned, we see vitamin D deficiency very commonly in PCOS. We also see it very commonly in endometriosis, chronic pelvic conditions. We're learning about it more and more being impactful for a lot of hormonal conditions, and infertility or fertility issues. So it's such a benign like supplement. Like we don't, or like, well, that's cute. It's just a little vitamin D. No, it's like it's huge. And this is like a whole aside because again, I could talk about PCOS for like 2 more hours. we're seeing really interesting immune implications with PCOS. Oftentimes, people with PCOS also have elevated thyroid antibodies, so like Hashimoto's, very common with people with PCOS having Hashimoto's, or Hashimoto's is being misdiagnosed as PCOS. So this is like a whole kind of area of like self-learning research, clinical case studies, investigations for me. Like this is like driving my practice. This is wild stuff to me. So vitamin D is very, very important. Okay, there's a question just around, I'll come back to that one. Told by a naturopath that berberine can cause liver damage long term. Is this accurate? I haven't seen it clinically, but again, if we want to monitor liver function anyways, because again, you could be at higher risk for fatty liver disease and those kinds of things as well. So the berberine might not be causing the liver issues. You might already have just elevated liver enzymes due to the insulin resistance under the factor. But clinically, I have not seen berberine cause that. When should you take Canadian bitters? So I always say kind of like 5 to 10 minutes before eating. I know I'm packaging like 30 minutes before, but anything you can do kind of to prime digestion, but better late than never. Take your bitters. I love it. Yeah, one of my faves. When would you take licorice, i.e. before a meal? I like dosing it first thing in the morning. Licorice is also an adaptogen, so it helps with cortisol levels, and I know that's a big thing with cortisol and insulin resistance. There'll be more webinars on that. So yeah, licorice, great adaptogen. So I like dosing it in the morning because it kind of helps that cortisol curve for the day. And generally herbs, we like them on an empty stomach. But I would rather people take it and yeah, don't let perfection be the enemy of good. So HOMA IR score is calculated by using fasting glucose and fasting insulin. Correct. Yeah. So I would say 12-hour fasting for both. And I find a lot of people aren't running insulin. And a fasting glucose may not tell us if you have insulin resistance or not. I see this really, really common clinically because our body wants to do the thing. Our body wants to lower our sugar, and it does it until it can't. So oftentimes people have a super normal fasting blood glucose or fasting sugar, but high insulin is kind of bubbling under the surface for years. And then all of a sudden it's like diabetes. I don't know how many people have been like, yeah, I was fine and fine and fine and fine. And then all of a sudden my doctor told me I had diabetes. So I'm like, consideration that we run our insulin as well. You can do some cool calculations with cholesterol because cholesterol can also tell us a bit about insulin resistance as well. There's some cool calculations out there. Is fasting insulin test covered by OHIP? I think that's an Ontario thing. I'm sorry, I'm not from Ontario. I don't
Yeah.
know.
Is it covered in Alberta?
Hmm?
Is it covered in Alberta?
So, as a naturopathic doctor ordering tests, it's either people's insurance or them that covers the cost of testing,
Yeah.
regardless of what I run. Sometimes people's medical doctors will run insulin for them. It's very hit or miss, and oftentimes they'll run like a fasting glucose or an HbA1c, and they're like, it's normal. Yeah, but I've had a lot of I told you so moments for doctors that didn't want to run
Yeah.
blood work, and then their insulin came back at like 200. By
Oh,
context,
wow.
I want to see it like ideally less than 40. And yeah,
Okay.
their glucose was over 10. And I was like, I told you so. But again,
Yeah,
it's
there's some people saying yes, that it can be covered.
okay.
Fasting insulin is covered by OHIP. So,
Yeah,
um, yeah,
yeah,
but it's really having that conversation with your doctor. So,
yeah, yeah, for sure. Yeah. Okay, so is high DHEA also so with PCOS? Yep, so we went over that on our slide. So it's another type of androgen. It's coming from the adrenal gland. Oftentimes we can call this like adrenal PCOS or lean PCOS. So when doctors like, you don't look like you have PCOS, you could have adrenal or lean PCOS. Does it cause hair loss? It can. Yeah, for sure. Again, any of those androgens can be associated with that. Yeah. Uh, So if you're experiencing 0 to 2 periods a year, is the only option an IUD or like an oral pill to mimic a cycle since higher risk of the cycles being abnormal? Um, so it's either treating the issue, so again, the insulin resistance, potentially herbs that are looking to regulate the cycle and get more consistent bleeding. I will put the caveat with patients. So if we are doing things and they're not seeing a period within 6 months, for me, I'm telling them you need to do a progesterone withdrawal. So people will take a short course of progesterone, and then when they stop the progesterone, then they bleed. So it's a good way of trying to induce a cycle. I see that also some people struggling with fertility, that they're like, even to do the testing or those kinds of things, they have to have a period first to do that. So they'll take a short course of progesterone. But yeah, those are the most common if we can't induce a cycle naturally, that we're talking about other hormones that are protective for the uterine lining, or we're using hormones to kind of mimic the cycle to induce a bleed. Yeah. So can all the herbs I talked about be taken daily? Can they all be taken at the same time? Uh, yes to all. Milk thistle, super safe long term. Licorice, super safe long term. What else did I talk about? Some of the anti-androgens, saw palmetto,
Hitters. Yeah.
reishi, bitters, all of them super safe long term. And just doing the constituent math in my head, is there anything that can't be taken together? I don't think so. I think they could all be taken at the same time. And oftentimes, like formulations, we're incorporating a few of those herbs together. So it might be licorice and milk thistle and those kinds of things all in one formula. And you're like, here you go. And it makes it nice and easy. So we got that. So healthy fat, I'm talking about like omega-3 fatty acids. I'm talking about nuts and seeds, flaxseed, avocado, versus like a lot of trans or saturated fatty acids. Yeah. Kind of guiding towards more of like the Mediterranean diet, where we see a lot of research with those healthy fats, so the olive oils, etc. Okay, so can I highlight the importance of building muscles for longevity, especially at PCOS, but also as you age? Yeah, so aging in general is what we call like a catabolic process. Like we're breaking things down more quickly than we can build them, right? So I talk about like muscle as your longevity factor, because if you don't use it, you lose it. And sarcopenia or muscle loss is really common as we age. So especially when we're able to building muscle mass is going to be important to prevent that muscle loss, muscle weakness, etc. And again, I talked about like stabilization, and we always want to prevent like fracturing of a hip. That is like a big thing. And for us, like again, kind of getting into geriatric population, that kind of thing, we want to be very protective against falls and then fractures as well. I don't know if I fully answered your question, but I know. Okay.
And do you have any insight? There's someone who asked a couple times now, why strength training would make their PCS worse. Any insight into that, or?
Usually, and this doesn't have to be just necessarily strength training, but it can be any type of activity where we see what we call a relative energy deficiency. So especially when people are trying to lose weight, they're calorically restricting, meaning they're
Mm,
getting calories, they're under fueling. And so when we're under fueling comparatively to our activity level, we actually increase a lot of those brain hormones. So our follicle stimulating hormone or luteinizing hormone are really high, and we can see um, uh, hormonal impact. Like even on like if you are relatively energy deficient for a day, we can see that being impactful for your hormones for multiple days after. So sometime, and that's why like especially with fertility, people are saying like exercise less, or that's been a lot of doctors who are like people who are lean and under fueling. It's not a matter of like exercise less. You probably just need to eat more. Yeah. Because again, we need to be more supportive for that, for your calorie intake. And strength training is a high calorie demand activity. So we want to make sure that we're actually adequately fueling for that, including high protein. And again, if we're restricting calories, and a lot of times doctors are saying restrict your carbohydrates. Surefire way for relative energy deficiency because we get good calories from our carbohydrates. So that could be why. Again, I don't know your case specifically, but most commonly we see it being related to that relative energy deficiency. Yeah.
We'll just do a time check, Brianna.
Yeah,
What do you think?
7:05.
Okay.
I'm good to keep going for like 5-10 minutes, but
Okay.
if you want to
Okay.
bounce, that's okay too. Yeah. Was there any burning questions that you saw, Caitlin?
There's
Or
a few questions that I saw. So sorry, I'm just I put some to the side over here. So maybe you could just clarify, is there a difference between insulin resistance and inflammatory polycystic ovary syndrome?
I think it's the
Or
same. Yeah, I
yeah,
think
okay.
it's the same. Yeah, because usually the inflammation is coming from the insulin resistance. And so yeah, inflammatory PCOS could just be basically that insulin resistance. Yeah,
Okay.
because chronically elevated blood sugar is going to be very inflammatory. Yeah. Yeah.
Have you ever heard that black cohosh can give people nightmares? Have you heard that as a side effect?
I haven't, but I'm
Okay.
curious if the dopamine is a factor with that because I know it can
Okay.
influence that. There's some weird things that people have told me recently. I'm like, I don't know why
Oh,
that.
that's different.
Yeah.
Because herbs can interact in a person's body differently, right?
Yeah.
It is,
Yeah.
yeah, yeah.
Yeah.
Just
Yeah.
be very mindful and aware, and yeah,
Mhm.
it can be
Yeah.
different.
Yeah. And
Um,
yeah. And for me, for like, for the sake of education, like obviously
hmm,
about all the herbs that could be beneficial. So you can't, and again, I picked a lot of herbs that are very universally safe and very universally tolerated. Again, because we can get really specific that we're using herbs for certain symptoms or we're using herbs. And again, sometimes it's just more streamlined. But I
hmm,
chose herbs intentionally that are generally safer and good long term. Yeah. But yeah,
okay.
if one herb doesn't work for you, there's probably a herbal friend that can. Yeah.
Yeah, yeah.
Yeah. Yeah.
Um, what if you have fatty liver? Are any of these, can these help, or will it worsen symptoms of fatty liver? But yeah, it'll
Yeah.
help.
Yeah, because
Yeah.
fatty liver is usually a byproduct of insulin resistance. Uh,
Ah,
yeah, so when we have lots of sugar and our body doesn't know what to do with it, we store it as fat on our liver. So it's kind of like a starvation mentality. It's like our body will just allocate it for storage. So yeah, we can see fatty liver disease being really associated with insulin resistance. Yeah, so I'm usually treating both. Mhm.
okay, great. Um, maybe just a couple more, Brianna. How much vitamin D should be taking a day?
Yeah, so the new recommended daily allowance is 2,500 units of vitamin D. So the old 1,000 units, we're actually seeing an uptick or an increase in that. And that is only for maintaining your levels. If you're
Okay.
deficient, you may need to do slightly higher doses. So I always encourage, like, especially if we're considering vitamin D deficiency, that we're getting that tested and then we're adjusting the dosage appropriately. And that's where the injections potentially comes in. But I would say most people will do really well, 2,500 units every day. So I say that specifically because there are dosage increments like that, or you can fluctuate between 2 and 3. Yeah.
Great. Maybe we'll just do one more. And before I do that, I just wanted to say, if you have questions about St. Francis products or about herbs, you're always invited to email us at info@stfrancisherbfarm.com. You can also go on our website and go to contact us. And I think there's a form to fill in there. If you have questions, especially about herbs or St. Francis products, we're happy to answer those there. Someone had a question about, what are your thoughts on plant-based eating and PCOS?
Um, there people, all forms of diets, people do well or people don't do well. I know a
Right.
lot of vegetarians who are carbitarians,
Yeah.
where they're not eating plants, they're not eating vegetables.
Yeah.
But I would say there's certain potential deficiencies that we see more commonly with hormonal conditions. Like as I mentioned, B9, B12 deficiency, super common in those with PCOS. And we know that sometimes plant-based diets are limited in those nutrients. So it's not that you can't do that. We're just very conscious of like certain nutrients that you may not be getting from your diet. Choline is a good example. Like oftentimes plant-based diets, they don't have a ton of choline. Choline's a really important nutrient in pregnancy. So again, different considerations based off of either hormonal conditions or stages of life where you may have an increased demand of certain nutrients. So you can do it. We just have to be very intentional about it. Yeah.
Yeah, good insight. Well, thank you, Brianna, for sharing all your knowledge this evening and taking that herbal approach to PCOS, which can be, yeah, really tricky and really difficult in a woman's life. But there's hope and there are some solutions. So um, again, you're more than welcome to reach out to us directly with herbal questions or product questions, and we're always happy to help. And we'll hope to see you again on a webinar. Have
Great.
a good
Yeah.
evening,
Thanks,
everyone.
everyone.
Yeah,
Bye.
bye.